Good Monday, snowy morning. Welcome to Labor and Health this morning. Couple of quick reminders before we get started this morning. Please leave your cell phones on. If your cell phone goes off in the meeting, you buy donuts for the next meeting. I brought my own this morning because audience has been very unhelpful. Nobody leaves their phone on. So welcome. We got two bills in front of us this morning. First one, Senator Pappas is going to present to us. It's called Occupational Therapist Criminal History. Looks like a fairly reasonably short bill. Come on up, Senator Pappas. Welcome, sir.
Thank you, Mr. Chairman, committee. Yes, this small bill is almost just a technical correction. It came to my attention, the board was having some issues with being able to obtain the information from the FBI for criminal history. And come to find out, in our statute that we passed, it says all persons applying for a compact privilege. Well, they didn't like that. And so they wanted the specific title of the person applying. So it's all we're changing is persons to currently licensed occupational therapists and occupational therapist assistants. A couple of you, I believe, yourself, Mr. Chairman, and Senator Barlow actually co-sponsored this bill. At least, if you notice, your names are not on there. There was a snafu. The LSO changed the catch title, and since the catch title was changed, they dropped all the co-sponsors. So I apologize, but I didn't catch that. But that's all the bill does. I do believe there actually many states are kind of in the same predicament, and they're going through this to try to get their bills, to try to get the background checks from the FBI. And I understand that there's actually a bill in Congress to make them do that, but we'll just fix our statute with these first few words, and hopefully then we can get those background checks.
I suspect that the congressional bill will have 50 other pages of non-associated things with it, like we don't do in Wyoming.
You're probably right, Mr. Chairman, and it'll probably take a lot longer.
Quick question for you, Senator, and that is, I noticed it says currently licensed occupational therapist. Do we have anything for new licenses, or was that all right in the statute as we had it?
I don't know. I guess I'd have to look at that. I think it's they have to be licensed in order to practice under the compact. So you have to have a license first, then you can apply to practice under the compact. So if you're not licensed, you can't practice under the compact. So the background check is, you don't need it.
Right, that makes sense.
Yeah.
That makes sense. You got my brain working this morning.
Yeah.
Questions for Senator Pappas committee? Lynn had her finger on the button, but.
No.
Okay.
Okay.
No questions.
Thank you, Mr. Chairman.
Stand by. Any folks from agencies, departments wishes to comment on this bill? Come on down, the middle seat's warm. Not really warm, he wasn't there very long.
Thank you, Mr. Chairman, committee. Greg Searles from the Professional Licensing Board Office, and I'm the Executive Director for the Occupational Therapy Board. Chairman Baldwin, to answer your question, background checks are not required for initial licensure for occupational therapists in the state of Wyoming. And with that, I would stand for further question.
Thank you. Thank you for that clarification. I suspect that when they work in somewhere like a hospital setting, et cetera, that then they end up doing the background check anyway, but that's interesting.
Mr. Chairman, that's my understanding, is more of them are done at the employment level than at the licensure level, correct?
And if they want to be part of the compact, then they'll go ahead and do it. Questions for Mr. Sherrill committee? Senator Dockstader.
Just a clarification of who and where you're from. I haven't heard you testify before.
Senator Dockstader, Chairman Baldwin. I'm Greg Searles. I'm part of the A&I Professional Licensing Board Office.
Oh,
and I'm the one of only 7 boards is the Occupational Therapy Board.
thank you, Mr. Cyril.
Okay, thank you very much. No further agencies. Anyone from the audience here in the room wish to testify on the bill? It's going to take a while to get folks going this morning. I think we have one online. Is that correct?
Mr. Chairman, we do have several people online, but no one with their hand up at this point.
Oh, okay. I had Shannon Moodry was listed for 152.
And she has not joined yet.
Okay, she thought we were going to be slower than we are. Okay, thank you. Last call, anyone in the room wish to testify to this bill? In that case, we'll close public comments. Committee, what's your pleasure? Moved by Senator Dockstader, do pass. Any comments, changes, questions on the bill, committee? Hearing none, pretty straightforward, pretty simple bill, just a correct, really a technical correction. Okay, with that, let's do roll call on Senate File 152, please.
Thank you, Mr. Chairman. Senate File 152, Senator Barlow.
Aye.
Senator Bouchard. Senator Dockstader.
Aye.
Senator Hutchins. And Chairman Baldwin.
Aye.
We have 5 ayes. Who would like to present it?
Senate File 152 is passed to the Labor and Health Committee in the Senate. Senator Pappas will present that on the floor. Thank you very much, Senator Pappas. Okay, that brings us to Senate File 151. Wyoming Prescription Drug Transparency Act. I assume, Senator Hutchins, you're going to present that to us.
I'll try.
Okay. An immediate lifeline, that's good. Okay, Senator Hutchins, the floor is yours, ma'am.
Thank you, Mr. Chair, members of the committee. Thank you again for being willing to hear this proposed piece of legislation. In the last 2 years, I have not met a group of people that have worked so hard for their survival. And I literally mean that. The pharmacists have come together to appeal to and lobby you for their grievances. This is not just a job for them. They're here they're not here receiving thousands of dollars to lobby, but they're doing this to protect their livelihood, families, and the communities they live in. I look at our local pharmacists as an endangered species. This bill, called the Wyoming Prescription Drug Transparency Act, was one that they brought to me. We were able to pass out of the Senate File 36, which dealt with pharmacy benefit manager reforms last year. This one, we just kind of simplified things a little bit and just are dealing with prescription drugs transparency. So the act, as relating to the insurance code, is prohibiting specific acts by the pharmacy benefit managers. And as you can see, it's allowing the individuals to choose in-network retail pharmacies that specify providing definitions, amending a definition, requiring pharmacy benefit managers to provide contact information as specified, and so on and so forth. I don't know if you want me to go through the whole bill, the whole act for you. If we go to page 2, lines 5, you see transparency prohibitions. These are listed because this is what's happening to our local pharmacists. We have a list of shall nots, starting on line 8. The pharmacy benefit manager shall not, Romanet I, cause or knowingly permit the use of an advertisement, promotion, solicitation, representation, proposal, or offer that is untrue, deceptive, or misleading, charge a pharmacist or pharmacy provider a fee for any of the following: Those are listed on page 2 through 3. And then line 12 on page 3, Romanet 3, retroactively deny or reduce reimbursement for a covered pharmacy service or claim after adjudication of the claim unless, and there's a list there of the unlesses. And then on page 4, conduct spread pricing and prohibit a pharmacy services administrative organization, contracting agency, or agency of a pharmacy from sharing upon request copies of pharmacy benefit manager contracts with requesting pharmacies or departments of insurance. And we can go on with the rest of the items that they'd like them not to participate in. And then on page 5, let me see, we start our definitions, and those definitions go on throughout the bill to page 9, where we have, let's go to page 8, where we have line 7, the maximum allowable cost, offering information on alternatives. Line 20, a pharmacy benefit manager shall. Page 9, line 5, what a pharmacy benefit manager shall do. And then on page 10, K, what they shall not do. And then we have on page number 11, we're adding in here section 3, the Department of Insurance is authorized a full-time position. And I went through it quickly because I'm assuming you read the bill, you kind of have an idea what's going on in the bill. So we're not here all day. We also have some handouts for you from the pharmacists that I'd like you to pay attention to. And I think Mr. Scott to my left will go over some of those or answer any questions that I can't answer.
Go ahead, sir, introduce yourself and. go
Thank you,
ahead.
Chairman Baldwin. My name is Scott Schmidt. I own North Star Pharmacy and Infusion here in Cheyenne. I want to thank each one of you on this committee and those that have sponsored this bill and for all your help and diligence in getting it to this point. So hopefully we can get something done this year. First and foremost, I think Senator Hutchins said it best. You know, we're fighting for our existence. And each year it gets harder and harder to do that. In a handout that we have, I have a paper that's been backed up by NCPA, the National Association of Boards of Pharmacy. And it's independent neighborhood pharmacies, accessible and affordable care, trusted and valued healthcare providers. And in the state of Wyoming, as of 2021, this is when the data was put out, there was a total of 46 independent pharmacies throughout the state. Those 46 pharmacies had total sales of $185,426,000. The pharmacy sales were $173,373,310, and just the over-the-counter sales was 12 million. Total number of employees were 566. Now, if you look at that impact on just 46 stores, and a lot of those stores are in rural Wyoming. And those are the only providers possibly in those communities. And so if we don't do something to increase the transparency from the PBM side of things, they continue to use their authority and keep clawing back money from each one of us. And so we're asking for your consideration in this bill that not only have we done this for 2 years now, but just the impact on my store alone. From 2021 We were under reimbursed 233,000. And in the interim, as we delayed this another year, 2022, my losses went to 313,000. So that was an increase of $80,000. And that's a lot of money for just my store. Now, if we take 46 of these stores and combine their losses, we just want to know where is this money going, who's getting it, and why is it happening this way? This bill will allow us to kind of hold the pharmacy benefit managers a little accountable because there's no regulatory agency over them right now, oversight. And everything that we do is accurate to date. They get to see our claims being adjudicated, how we're reimbursed, and so on and so forth. And they can come back and audit us even further for claims that have happened 2, 3, up to 7 years ago. So we're just asking for your consideration in this bill that we can actually get something done in the state of Wyoming, because this would be a tremendous help for us. And we're not asking for a lot. Again, we're just asking for a fair playing field. And we're willing to show our cards. Now we just ask them to show their cards as well. So also, in this handout that I have, it's called PBM Reform has not raised the cost for patients and payers. And as you can see in this data, again, from NCPA, it doesn't cost the states to implement this type of legislation. Those that have done it have showed that if you look down in Louisiana and Tennessee, states that prohibit PBMs from reimbursing PBM-owned pharmacies at a higher rate, non-affiliated pharmacies. The United States, it's the rest of it's 3.5% better margins, but what Louisiana and Tennessee have done, they've lowered those costs to the state. And then if you look to the right of that, states that protect patients from PBM penalties, higher copays for utilizing in-network pharmacies of their choice, that's a pretty substantial number when it's 28% higher than those that have some PBM reform. And those are big dollars. And so again, where are those dollars going? They're definitely leaving the state of Wyoming, going to corporate America. Again, states that protect patients from mandated use of mail order pharmacy, again, costs have not gone up to the state or to their plan. And Georgia and West Virginia highlight that. Again, we're coming with data that's been backed up and certified, and during the interim, I didn't think that kind of helped us on the opposition side. They didn't come with any data, and so it's just these hypotheticals. So again, another handout that we have here that you have to have a microscope to see because I can't even see it. I apologize, but these are all the states that have implemented PBM legislation. Every state. So it's time that Wyoming gets involved so we kind of have some fair playing field as well. So any questions for me?
Questions for Mr. Schmidt? Or for Senator Hutchins? Senator Bouchard.
Thank you, Mr. Chairman. I like to see this thing about Tennessee because that's one of the states that I followed rather closely, even talked to the senator there that was actually a pharmacist that brought their legislation. So from what I understand of this legislation, this is only a fraction of what they did in Tennessee. So would you not agree that there shouldn't even be any opposition on this bill compared to what Tennessee did, and Tennessee actually lowered the price. So comments on that, please?
Go ahead, Mr. Schmidt.
Chairman Baldwin and Senator Bouchard, absolutely, I appreciate your remarks to that. Again, we're just introducing things to get the ball rolling, right? I think we've conceded on a lot of things to this point. And And again, yeah, there's definitely some room to improve on this and actually lower costs even further for our constituents here in Wyoming. And that's what we need to do. And again, I ask for you guys' support on supporting this bill.
Okay, further questions, committee? Go ahead, Senator Barlow.
Thank you, Mr. Chairman. So I just received this handout just now. I have no idea how to interpret it, right? Because I can hardly read it. But just to Senator Bouchard's, and any feedback is appreciated, but to Senator Bouchard's comparison of Wyoming to Tennessee, it looks to me like there's only three things that Tennessee has done that Wyoming doesn't already have in place. Just looking at the graph. And like I said, I'm just looking at it quickly. So my question is, the legislation before us, does it actually implement all the rest of these as well in Wyoming? Thank you. That are not currently on the books. Thank you, Mr. Chairman.
Senator Hutchins?
Thank you, Mr. Chairman and Senator Barlow. I believe Senator, and I could be wrong, but I believe Senator Bouchard meant Louisiana. He was the senator that I spoke to that was on our NCSL web kind of educational piece on the PBMs. So if you look at Louisiana, you see a lot of the legislation that they proposed and got passed. So what this graph is showing you, or this chart, are the, if you look at the top and look at the left, you'll see the states, and then on the top, you'll see the legislation that they've passed in their states as of 2023. So Wyoming is kind of lagging, but like I said, we're trying to catch up and get some legislation done for our pharmacists here, especially our rural pharmacists. Does that help a little bit?
Go ahead, Senator.
Thank you, Mr. Chairman. Well, I guess I just want to know the frame of reference, and I was told to look at Tennessee, and now I'm being told, no, look at Louisiana. So thank you, Mr. Chairman.
Mr. Chair,
Go ahead, Senator Hutchins.
I said I believe, and I could be wrong, so we should allow Senator Bouchard to clarify on his behalf.
Go ahead,
not
Senator
mine.
Bouchard.
Thank you, Mr. Chairman. No, it was a pharmacist in Tennessee who was actually a legislator there that I spoke with. Senator Barlow, we had a lot of interaction on this legislation. And I'm just referencing how when you're trying to make a bill, and then the other side just keeps saying, what about this? What about this? And what about this? By the time we took a 12-page bill and turned it into a 50-page bill because opposition didn't like everything that we were doing. But the bottom line is what Tennessee did when I spoke to the senator there. They had PowerPoints for the legislature to look at. There was a big association for the pharmacists that did a lot of presentation, and they were able to get the things that we were trying to do last year into their bill. We're only doing a fraction of what they're doing, but we are trying to bring transparency into the picture with this bill.
Senator
So
Barlow.
I hope that answers some of the question here.
Thank you, Mr. Chairman. I don't know that it helps, but so which fraction is it? And you can get to this because you give us columns, you say,
Yeah.
check the boxes. So which boxes are we checking? That's the point I'm trying to make. Thank you, Mr. Chairman.
Pardon? All right.
Go ahead, Senator Hutchins.
Mr. Chairman, Senator Barlow, I'm going to introduce you to pharmacist or Dr. Melinda Carroll here in a moment. And forgive me for misspeaking for Senator Bouchard. The senator from Louisiana was also pharmacist, so that's where I thought that he and I kind of crossed paths. But there are two different senators, and they're both pharmacists from two different states. So Melinda Carroll will help explain the chart.
Go ahead, Ms. Carroll, introduce yourself and go
better
ahead.
than I did.
Good morning, Chairman, committee members. I'm Melinda Carroll. I am here representing the Wyoming Pharmacy Association, which represents pharmacists, technicians, pharmacy owners, stakeholders in pharmacy throughout the state. And yes, Senator Barlow, as you pointed out, we do have some columns marked in there that we had worked on legislation previously, which we were grateful for. However, it didn't change the landscape for the pharmacists in the state, unfortunately. Those pieces of statutes, the prescription benefit managers were able to get around and find different ways to do it to prevent those statutes from really having an effect on the state. I realize that the topic of prescription benefit managers is not new to many of you, and you will all have likely heard conflicting information on the topic. I'd like to emphasize that I will be transparent in what I have to say and only represent information that is verifiable by the committee. I'd like to share with you that at the direction of the Corporation Committee, industry and pharmacy stakeholders met over the interim to work on language acceptable to both parties. Over the course of 5 meetings, the working group was unable to come to agreed upon language. Unfortunately, the industry stakeholders would not compromise on the top 2 concerns of Wyoming pharmacies, which were adequate reimbursement and freedom of choice for Wyoming citizens. The pharmacy stakeholder group drafted language on these issues, and that was not agreed upon by those industry stakeholders. In fact, in the meeting on November 8th, industry representatives declined to work with the pharmacy representatives regarding reimbursement and patient freedom of choice, stating that it is plan design and it is not negotiable. This came as a disappointment to pharmacy stakeholders, as they felt that they were misled on what the working group was tasked with accomplishing. Those I represent feel that the current crafted language of Senate File 151 is a significant compromise from Senate File 36, which passed out of the Senate in 2022. And it would still help address the concerns and potentially prevent further closure of pharmacies in the state. We also hope that the industry representatives would acknowledge that compromises the pharmacy stakeholders did make in this process. PBM reform is needed to address these issues and ensure that the system works effectively to keep drug costs down and ensure that patients receive the most appropriate medications for their conditions. This can be achieved through measures such as increasing transparency in PBM pricing and negotiation practices, addressing conflicts of interest, and implementing regulations to prevent spread pricing. Senate File 151 is a step in this direction. This bill requires drug pricing transparency on all medications. It allows pharmacies to appeal, yes, just appeal, underpayments on all medications, not just generic medications, which is not where pharmacies are losing hundreds of thousands of dollars. This bill also greatly increases transparency in those appeals, requiring PBMs to report at which wholesaler the medication is available on the date of dispensing at the reimbursement rate that was paid to the pharmacy. If the PBM fails to meet these standards, pharmacies can submit a complaint to the Department of Insurance, which will then complete an investigation into the complaint of underpayment. This is not a guarantee of profit for the pharmacy, which you may hear as an argument against such measures. This bill also requires a community pharmacy to be included in network, eliminating PBM's requirement to use only mail order pharmacy that is often owned by a PBM. This allows patients to choose the pharmacy that best meets their needs, whether based on location, hours of operation, services offered, or the type of medication they need. This is especially important for individuals who live in rural areas like most of Wyoming. For example, those who have mobility issues, live in weather-sensitive areas, or have a relationship with a community pharmacist, as it allows them to access pharmacy services without traveling long distances, sacrificing healthcare relationships, or not knowing if their drug is viable to use. Finally, this bill requires reform to audit practices. PBM audit practices lack impartiality, as they are incentivized to conduct audits that result in clawbacks, which is recouping funds paid to a pharmacy for prescriptions prescribed for a legitimate reason and used by the patient for that legitimate reason. These clawbacks increase profit margins for the PBMs rather than ensuring accuracy and fairness in reimbursements. PBMs conduct audits months or even years after a transaction has occurred and may demand that the pharmacy repay funds for transactions that were already considered settled and that the patient has already received the benefit of the medication. This can be especially harmful to small independent pharmacies as it can put them at a financial disadvantage compared to the larger pharmacies that can absorb the cost through sale of other items, although these practices still are detrimental to the larger pharmacies. Overall, regulations on PBMs are beneficial, as we've been shown. PBMs hold monopolistic power. Regulation increases transparency in PBM pricing and negotiation practices, addresses conflicts of interest, prevents spread pricing, and holds PBMs accountable for their actions. This can help ensure that the PBM industry is working effectively to keep drug costs down and ensure that patients receive the most appropriate medications for their conditions, while also ensuring that access to care in Wyoming is maintained. We are asking our elected officials to look at correcting the market imbalance that has occurred where the golden rule, which was summarized by an industry insider quite well, whoever has the gold gets to make the rules, has reigned supreme for at least the last 20 years. Without addressing this issue, we will see further pharmacy closure in the state and decreased access to healthcare by Wyoming citizens. In regards to your question, Chairman Senator Barlow, there are about 10 provisions that most pharmacy organizations have said will help control these conflicts of interest for PBMs. If you look at Wyoming, we have 4 on the books. Oh, they only put, 4 on the books currently, which is not close to 10. So we are trying to add a few more in there regarding reimbursements and appeals. So that would be provisions addressing non-MAC reimbursements. We're also trying to address prohibiting against arbitrary accreditation requirements.
Hold up 1 second. Senator Dockstader, you have a question?
I have to step out for a minute, but I do have a question before I leave. On the provisions, reimbursement and choice sounds unresolved. Is it still that case? Yeah, I know you're right in the middle of trying to explain it, but if you could hit that for me real quick before I leave.
Go ahead.
Chairman, Senator Dockstader, those provisions are addressed in Senate File 151. They are compromises from Senate File 36 from last year. They give pharmacists a route to address those issues. It just requires a community in-network pharmacy, and it requires appeals on all medications. So yes, those 2 issues are addressed in this legislation. Again, unfortunately, the industry representatives did not want to endorse this particular piece.
Thank you.
Further questions, committee, for this group? Sensing none, we'll let you guys have a seat. Oh, go ahead. Senator
Mr.
Hutchins.
Chairman, members of the committee, thank you so much for letting me have these lifelines. They, as you see, just from the simple testimony, they just know so much more than I do. They tell me, and then it's like, ooh, it's way too much information. So I hope you guys are picking up on it. I know Senator Barlow was not here last year to hear the endless testimony we had on this subject. So thank you so much.
Really quick before the senator
Don't
leaves.
run away,
You
Senator.
may not need your lifeline with these. This is looking over from last year to this year. We have some changes in there. What did you think were the most important changes? Just update from what we nearly passed last year.
Go ahead.
Thank you, Mr. Chair. Senator Dockstader, it's amazing how they trimmed it down. I think we had 22 pages last year, and this year they're only dealing with 1 topic. And I commend them for doing that. Let's just get the most important thing, and that's this transparency on our prescription drugs. So,
Thank you.
thank you.
Mr. Chairman.
Oh, Senator Barlow.
Mr. Chairman, so before these folks leave, so which columns, I mean, I've read the bill, I worked through the bill. I looked at last year's legislation as well. I actually think I understand some of the difference between the 2. So what I want to understand is what columns are we trying to check off with this? And some of them are very straightforward, some of them are partial. I can see some of them are just partial. So which columns, left to right if you want, are we trying to check off here with this bill? Thank you, Mr. Chairman.
Go ahead, Ms. Carroll.
Chairman, Senator Barlow, thank you for that question. So we are trying to check off the second column. We're updating our statutes to the fourth column. We were told that the sixth column, Wyoming has statute in place for any willing provider, and the Department of Insurance has said that they are going to try and work pharmacy into that. So we have not pursued that at this point, but it's addressed in a roundabout way. We are redoing the reimbursement for appeal procedure, which is that seventh column. We are addressing the provisions addressing non-MAC reimbursement methodologies. That is the eighth column. And we are dealing with the ninth column, protections from under reimbursement, and then the 10th column, reimbursement to PBM-owned pharmacies. So that's all pretty much in one section of that bill. So as we kind of narrowed it down to try and include those under reimbursements and really just that freedom of choice. And so anything that deals with those two topics are columns that we are trying to address.
Thank you. Thank you.
Okay. All right. Have a seat. Any agencies or departments who wish to testify? Come on up, sir. Welcome.
Thank you, Mr. Chairman. Mr. Chairman, I'm Commissioner Jeff Rue from the Department of Insurance. We're neutral on this bill. We note that, as you'd heard, that this bill is similar, not identical, but similar to the one that was worked on during the interim with the group that I sort of mediated. I moderated those discussions as best we could, and I'm neutral on that bill too. And so I'm trying to keep that role, because I was specifically asked by Representative Zwanzer to take that on and see if we could get the parties to agree to something. I will leave it up to the various parties to discuss the differences and the impact, because once again, I want to stay neutral on this bill. This bill does contain an appropriation for our office to hire a person and to train that person to become proficient in PBM regulation. It is a whole new vernacular. I joke that it's like we're regulating something in French, and none of us speak French. We can get out of the translation book and work it, but it's very hard, and we just don't have the manning nor the expertise. I appreciate Senator Hutchings putting an appropriation in this bill for the person and the training, and that's actually what we're going to do with our discussions over the summer. That's what the group thought we all came to an agreement on, and I told them that's what I would be looking for, and I took their input on that. So I want to be here to answer any questions on that you may have. I based our work estimates on talks with other states. This bill is certainly not as rigorous, I guess, as Senate File 36 was last year. That's why the appropriation we're asking for is about a third, less than a half of what we were going to do there, because it's not as arduous. But I'd be happy to answer questions on the appropriation aspect or anything else you may have. If you want a brief synopsis of our office and our manning and how our bills are paid, we are a special fund department. Nothing in our office management, none of our people, our copiers, our notebooks, our computers is paid for out of the general fund. I note that when looking at this appropriation, it is out of the general fund. I think an easy, palatable modification would be to make it out of special funds, and I would just roll it in with our regular budget. It'd actually make our life easier, and I think it wouldn't burden the general fund in any way. So, I mean, if you look at that page, I think it's on page 11, lines 9 and 11. Just put in special for general, and I think, like I said, we wouldn't have the burden on the general fund. So, I'm happy to answer questions if you have them. If not, I'll let two sides discuss the differences and the impacts of them.
Questions for Department of Insurance? Go ahead, Senator Hutchins.
Thank you, Mr. Chair. Thank you, Jeff, for spotting that on page 11. That should have been coded SRR, and I don't know how we missed that, but thank you so much.
Questions? Senator Barlow.
Thank you, Mr. Chairman. So the way the bill is structured, timeline-wise, is you get your employee immediately if you can get somebody hired, but it goes into effect July 1st. So what kind of a process would you anticipate does it require rulemaking? And if it does, is it conceivable that rulemaking would be done based on your understanding of the intent of this by July 1st, 2023? Thank you.
Mr. Chairman, Senator Barlow, rulemaking by then will be difficult, if not impossible. It sometimes takes a year to get rules through, is what we're seeing now. What my plan has been all along, I know some of the other states I talked with the commissioners of insurance, and I've asked how they've done training, and there are firms that specifically do this. And I'm looking specifically at West Virginia, where they brought in someone to train their staff, because they actually trained a number of people. They had a much more robust bill, and they had a large number of people that needed to be trained, so they brought someone in. I'd be looking at something like that. Assuming I can hire someone, I would try to bring them in immediately to train that person. We actually, last year, when Senate File 36 was out there, we sent out requests for proposals for just such things to assist us in matters involving PBMs and PBM regulations and the training. So we have contracts out there now that we can pick up the phone and bring someone in for training purposes. So that part would work. Rules probably won't. We won't get them done in time. We'll proceed as fast as we can with rules, but that's something too that we could ask the other states and the experts that do the training what their rules look like.
Go ahead.
Thank you. So one more question. It was referenced that any willing provider, any willing pharmacy is already statutory. So how long does it take to put that, implement what you think you already have authority to do? Thank you.
Mr. Chairman, Senator Barlow, the any willing provider is an interesting part of our statute because there was a discussion last year with Representative Wilson where the thought was it's already on the books, it's already there, we should be able to enforce it without any further change, although the bill last year did clarify that. So, is it out there on the books? Arguably, yes, it's already there. How we would enforce it, we'd have to get a complaint and do our best until we got people into who could actually competently look at the complaint. I hope that answers your questions.
For the question, Senator Hutchins.
Thank you, Mr. Chair. Mr. Rood, question on the effects of the legislation passage. The effects, will they be immediate in your office or just over time?
Mr. Chairman, Senator Hutchins, I've talked to the other states on this, actually this exact question. I said, what's your workload? What was it when you passed it? How did it increase? Has it leveled off? Has it gone down? And talking with West Virginia, Arkansas, and Oklahoma, and a few others, there's an initial spike. And then it has leveled off after a couple of years. It hasn't gone up, it hasn't gone down. They haven't asked for more people. They haven't gotten rid of anybody for lack of work. But there was initial spike. Under this bill, I would expect an initial spike. One of the things in this bill in particular, it specifies that these small pharmacists, who are really mom and pop shops, they don't have the time to make a lot of complaints. They're too busy just doing their job every day. And so they will work with PSAOs, it's defined in here, who actually will do that function for them. I would expect a spike in complaints from them because that's part of their job. That's what they will do.
Thank you, sir. Ms. Rudin, quickly, does it rely on the PBM compliance with the new law that will kind of like they're complying with what they shall or shall not do, then you probably won't get that many complaints. Is that what this is based on? Thank you.
Mr. Chairman, Senator Hutchins, if there's compliance, logic would follow there wouldn't be a complaint, which would which would mean we wouldn't get the complaint. Some of the complaints I've seen in other states and some of that we received under the old statute are very minor in nature, but higher in number. So for example, you might have one prescription that was underpaid by 24 cents. But there might be, for example, like in Arkansas, they told me of an example where there's like 500 prescriptions that did that. And so they raised that one complaint, but 500 prescriptions attached to it, each one 24 cents.
Further questions, committee? Go ahead, Senator Barlow.
Thank you, Mr. Chairman. So you just made a reference to an old statute. I don't see any repealers in this. So what is the old statute? Thank you, Mr. Chairman.
Go ahead, Director.
Mr. Chairman, Senator Barlow, if you look at the bill itself, it references, it references 2652 and 101 on, and that's our existing statute, current statute, sorry.
Further questions to the Director, committee? Seeing none. Thank you very much, sir. And I know Franz, I believe, is across the hall. Jesse, could you look in, see if he's across the hall for us? I know he wanted to testify. Okay, hang tight. Go ahead, sir.
Good morning, Chairman Baldwin, members of the committee. My name is Ralph Hayes. I'm the manager of the Employees and Officials Group Insurance Program. Basically, I wanted to provide you some basic information and also be here to answer any questions you have as far as the fiscal impact statement from our program. Now, in 2021, we spent roughly $50 million in prescriptions, retail prescriptions for our membership. And this is the commercial plan, not those who are over age 65, which are really covered under the federal program, which is kind of carved out of this particular program. We're statewide because we have membership all across the state and participating entities. The Wyoming independent pharmacies that were referenced before, 10.8% of the spend was for those individuals, for those pharmacies. The rest were chain stores. So you're talking about Walgreens, there's 10 locations, Walmart, 12 locations, Albertsons Safeway, 13 locations, Kroger, 9 locations, Sam's Club, of course, 2 locations. So the bulk of our spend, if it's not we do have one mandatory mail order, which is specialty mail order, but the bulk of the spend is at the chain retail pharmacy. Now, removing, again, we don't mandate any prescriptions other than specialty medication to be done at a specialty pharmacy. As part of that, we do have a program called the coupon program. Now, you might have seen advertisements in various publications on TV, where if you can't afford your medication, contact AstraZeneca and they will help you out with those. Those are coupon program. Basically, it's to lower the out-of-pocket expense for the membership so it's less than the cost of aspirin for a $3,000 to $10,000 medication. Now, we have a coupon program that is actually offered by the manufacturers. They're the ones who pay this. And what we're able to do by mandating it through now CVS's, before it was MedImpact's pharmacy, is we get 75% of those coupon monies back, which lowers our cost. And that's where we get to the fiscal impact statement that we're projecting in 2024. That's worth $2.2 million. So that's a loss of revenue for those funds flowing to us from the drug manufacturers, which increases our cost, because what we have to do, since we're losing that revenue, we have to make it up in premium revenue. So we have to start charging the participating entities through employer contributions and the membership through their premium contributions to offset that loss of income. Mr. Chairman, that's all I really had, so I'm here now for any answers any questions you might have.
Questions, committee? Senator Hutchins.
Yes, thank you, Mr. Chairman. Mr. Hayes, do you have any charts or graphs or any detailed information that we can get from you to examine your statements?
Mr. Chairman, members of the committee, I can get you, I provided it last year, but I'm happy to provide that same information. I only have one copy in front of me, but I'd be happy to provide that to you.
Can we get that copy as soon as possible, like before the meeting's over, do you think?
Actually, if you give that copy to someone over here, staff, we can get that copied now.
Thank you, sir.
Further questions? Committee, Senator Barlow.
Thank you, Mr. Chairman. So I just want to be clear, the fiscal note is based just on the mail order for specialty drugs in the coupon program. Is that accurate, Mr. Chairman? Thank you.
Mr. Chairman, Senator Barlow, yes, it is.
Thank you, Mr. Chairman. So to extend that, if I could, what percentage of the total spend, 50 million, is this mail order? Independent pharmacies, you had 10.8, but what is the total percentage of the mail order component? Thank you, Mr. Chairman.
Mr. Chairman, members of the committee, the total, if we look at just the specialty medications, that's roughly $15 million. So being able to carve back $2.2 million of $15 million, I'm sorry, so it's several percent.
Just for clarification for those listening for the committee, define specialty drugs for us.
Mr. Chairman, members of the committee, specialty medications are generally medications which are biologic in nature. To give you some examples, of course, now my mind's drawing a blank. Generally injectables. I'm sorry, Mr. Chairman, but it is absolutely not coming to, I will tell you that the cost is generally, $2,000 on up. I mean, we have specialty medications that literally cost $20,000 for a month's supply. So they are very expensive. They're very few in numbers. In fact, you'll notice that those specialty medications were 3,193 scripts it cost the plan $15.7 million. So it gives you an idea on the specialty medication and how expensive they are. And often they require very special handling to refrigeration, things like that.
Very good, thank you. Didn't mean to put you on the spot. Senator Bouchard.
Thank you, Mr. Chairman. Can we have maybe one of the pharmacists come up and give a little more detail about these medications? And also, I want to add that we're looking at these just as numbers here. But the reason we're coming forth with this legislation is because there's people playing the field. And we have these local pharmacists that are subsidizing some of the things that are going on here. And so they're not getting reimbursed. And yet we get thrown numbers out here that on these special medications, if we weren't taking so much out of the pocket of our local pharmacists, there would probably be a different way that these numbers would come out different, because the whole thing is skewed. So anyway, if we could get some clarification on these drugs from one of the pharmacists, so we could get a bigger picture of what's going on, how it affects them as well. Thank you, Mr. Chairman.
Mr. Chairman, I will make one other point is I know in the legislation, they do talk about spread pricing. We do not have spread pricing in our program. When we go out for an RFP on this, that is specifically forbidden. So just so you're aware, spread pricing is not part of it. So whatever comes through as far as rebates or these discounts is passed 100% to the state.
Okay, Senator Barlow.
Thank you, Mr. Chairman. So prohibition against spread pricing, is that something the state does on its own when it does the RFP, or is that some other entity that prohibits it? Thank you, Mr. Chairman.
Go ahead, sir.
Mr. Chairman, members of the committee, this is something we specifically do through our RFP process. For a group our size, we know of its existence. Many, many years ago, we got rid of that spread pricing piece of it and went directly to the PBMs, and it gave us significant savings right off the bat.
I suspect Ms. Carroll's here to tell us about specialty drugs. Go ahead.
Mr. Chairman, Senator Bouchard, a specialty med would be something that would be like Humira, which is an injectable. It would be used to control things like an autoimmune disease. These medications are very expensive, and I would just like to let the committee know that many pharmacies choose not to carry these medications because of their expense. So it would be highly unusual if all of those patients that fill those 3,100 prescriptions to fill at a local pharmacy, I would find that to be surprising. I would say maybe 100, 200 might, but again, pharmacies generally, local pharmacies, even chain pharmacies do not carry those drugs because of the costs, the storage, the issues that are associated with them.
Very good. Thank you very much.
Mr. Chairman, members of the committee, just clarification on that. This isn't a total amount. This is not assuming everybody would move away from the specialty pharmacy. I actually found a study that was based around Medicare folks who were taking specialty medications and regular medications through mail order. And when given a choice in that study, basically, ultimately between 15% and, only 15% to 25% actually stayed with their mail order pharmacy, and the rest moved their prescriptions over to their local pharmacy. That's where this has come from. So this is not a 100% replacement. This is a scaled back based upon that study.
Okay, Senator Hutchins?
You mentioned a study. Do you have a copy of that study that you can give to us? And could there be a study out there that says just the opposite?
Mr. Chairman, members of the committee, I had very difficult time finding any kind of study that looked at this particular issue, and I latched onto the one that I could. So it was one study. I will have to refine that. I do not have that in front of me.
If you find out, you can email it to us. Okay, we'll give you a rest. Thank you, sir. Any further committees, departments, or? You escaped from across the hall. Good job. Go ahead and introduce yourself.
Just barely. Mr. Chairman, members of the committee, good morning. My name is Corey Cooper. I'm the Pharmacy Program Manager for Wyoming Medicaid. And my sole purpose here this morning is to explain that Wyoming does not, the Wyoming Medicaid does not use a PBM in the commercial sense. We are a fee-for-service agency where we do use a contractor, a vendor to process Medicaid pharmacy claims, but the decisions about how those are reimbursed and 100% of the reimbursement cost goes back to the pharmacy, and the decisions about how those reimbursements are made, what is covered, those types of things are made at the state level. So there's not a commercial PBM involved the way that this bill is trying to address. And I'm happy to answer questions about that, but my purpose here this morning is to point out that on page 7 of the bill, lines 1 through 5, the definition of a pharmacy benefit manager could be construed to include Medicaid and the arrangement we have with our vendor to process pharmacy claims. I don't believe it's the intention of this bill to include Medicaid in this bill. And quite frankly, we cannot abide by some of the things that are in this bill and also keep our federal funding. We have, in terms of reimbursement, we have a federal model for how we do that, an agreement with the federal government for how we do that. And so I would ask that to avoid reinterpretation or misinterpretation further down the line, that Medicaid be explicitly excluded from the requirements of this bill. I'm happy to stand for questions, but I know you have a lot of testimony to hear this morning.
Senator Hutchins.
Thank you, Mr. Chair. Thank you, Corey. I remember that happened last time, and so much work. That was an oversight. What section was that again? Page 7.
Mr. Chairman, Senator Hutchings, it's page 7, the definition of pharmacy benefit manager. And
Gotcha.
I don't know what language to suggest. I'm happy to work with you on that. But I do think that would probably be the best place that it would fit in the bill if the choice was to exclude Medicaid.
Thank you.
Would be in that definition.
And that was our intention. Thank you.
Okay, thank you.
Senator Barlow.
Thank you, Mr. Chairman. So I want to be clear, you're concerned about the current law may be interpreted to include Medicaid, or is it actually the proposed amendment to the benefit? Thank you, Mr. Chairman.
Mr. Chairman, Senator Barlow, I am concerned about this definition. I'm concerned about the requirements of this bill as related to this definition, the amended definition. So I hope that answers your question.
Further questions, committee? Seeing none. Thank you very much for coming.
Thank you.
Appreciate it. Okay, I believe that takes up all the agencies and departments. With that, we're going to open to the room. There's 4 chairs up here, folks. Occupy them, please, so we don't have big delays. We can keep things moving. Come on up. There's 4 chairs and 2 mics, so we share. Whoever wants to lead off, introduce yourself.
Good morning, Mr. Chairman and members of the committee. My name is Heather Roday, and I represent Blue Cross Blue Shield of Wyoming. I'm joined by Raymond Red Jr., our general counsel. We are an independent, not-for-profit company based in Wyoming for over 75 years and licensed to provide health insurance only in Wyoming. We make operating decisions locally, and we don't report to shareholders, which means any excess funds are put back into the business to ensure payment of future claims. We cover 125,000 Wyoming members plus 85,000 additional members through national agreements. These insured citizens depend on us to help make healthcare affordable through our insurance products. When healthcare costs rise, we must pass these increases on to our members through higher premiums. And some of our business clients are self-funded, large Wyoming companies who pay the claims themselves. And when they see their healthcare expenses climb, it directly impacts their bottom lines. Wyoming has some of the most expensive healthcare prices in the country, and we have concern when legislative bills such as SF 151 are introduced, which add to the price tag of providing insurance. Regarding this bill specifically, the introduced language limits the ability of employers to manage drug costs of their health plans by restricting PBM cost-saving services. It increases expenses through the elimination of coupon programs and claim costs, which will be passed on to employers. And it limits the medicines, it limits access to medicines when pharmacists are allowed to deny services to members based on how much the pharmacist services and receives in payment for the drugs. We estimate this bill as written will cost our organization and employer clients an additional $7 million every year on top of the price increases from drug manufacturers. Independent pharmacists are important to Wyoming, but this bill is not limited to them. Since 70% of our member prescriptions are filled at chain pharmacies, Wyoming members will be paying more to support chain pharmacies over and above independents. We ask you to resist Senate File 151 as written. Thank you, and we stand for questions.
Questions, committee? Senator Hutchings.
Yes, thank you, Mr. Chairman. Mrs. Roday, thank you so much. Appreciate your testimony. Just a concern, last year we were told this bill would cost $4 million or Senate File 36. And we've significantly reduced what we're asking in Senate File 151. And now you're saying $7 million. How do you justify that statement, if you can answer that? Thank you.
Go ahead, Heather.
Mr. Chairman, Senator Hutchings, this, as you said, is a significantly scaled down version of Senate File 36. Last year, we had estimated that cost was $48 million. So this represents a reduced cost over that figure.
Further questions? Nope. Senator Barlow.
Thank you, Mr. Chairman. So Blue Cross Blue Shield, 125,000 members. How many of those, what percentage of that is third-party administrative services you do on behalf of employers who self-pay or use your services? Thank you, Mr. Chairman.
Ms. Roday.
Mr. Chairman, Senator Barlow, it's roughly half.
Very good. Further questions, committee? Okay. Others at the table? Welcome back to Labor and Health. You have to speak pretty close to that mic there, so
Okay.
everybody in.
Good morning,
radio land can
Chairman.
hear. Very good.
Chairman Baldwin. My name is Lugina Mendez Harper. I am a pharmacist and I work with Prime Therapeutics, which is a PBM. We are owned by 18 Blue Cross Blue Shield, not-for-profit Blue Cross Blue Shield plans across the United States, including Blue Cross Blue Shield of Wyoming. We have been engaged with the Wyoming legislature since 2016, which is when the Wyoming legislature first granted authority over PBMs to the Department of Insurance. We re-engaged again in 2019 when additional requirements were put into place. So we have been under the regulatory authority of the Department of Insurance since 2016. This summer, we were asked by the Joint Corporations Committee to engage in a series of stakeholder meetings that were facilitated by Commissioner Rude to help us come together and have in-depth conversations where we could share with each other what are the problems we're trying to solve. It would give us the opportunity to, as the PBMs, to go back, talk to our people and say, here's what we're hearing. Can we validate this, and what solutions can we come up with? So that was the process that we used during this series of stakeholder meetings that occurred over from July until November. And in November, at our final meeting, we came to 9 pages of consensus legislation, and everyone in the room, including the pharmacists, agreed to support it. It's a consensus document. It represented negotiations. We didn't get everything we wanted. They didn't get everything they wanted, but it was something that we could agree on, that we could live with, that would try to address the issues that the pharmacists brought up. And I also want to share that the pharmacists set the agenda for those meetings. They were the ones that came in and said, here are the things that are important to us and that we want to talk about. And we went through those methodically to try and come up with that consensus information. The other discussion that we had was putting forth the question if we could entertain, if the pharmacists would be interested in entertaining a more directed piece of legislation that would specifically help independent Wyoming pharmacists. And that was rejected. The preference was to have a more broad piece of legislation or consensus document that would be the work product of all of our negotiations. So I want to discuss, there were 4 things that were noted by the pharmacists, and I want to address those kind of 4 major concerns. So the first issue that the pharmacists indicated wasn't addressed was patient choice of pharmacies. You heard Commissioner Rude testify, and we came to the table saying there is already any willing provider statutes in Wyoming, and we interpret that to apply to pharmacies. The Department of Insurance concluded that pharmacies did fall under that. So we felt that that was already addressed. On top of that, for Blue Cross Blue Shield of Wyoming, we don't have preferred pharmacy networks. Every pharmacy is in our network, meaning because this is such a rural state, we don't have the luxury of, like, say, a state of Texas where you have a huge number of pharmacies. That's not what we have here in Wyoming. So all of the pharmacies are in our network, meaning that a patient member can go to any of those pharmacies. Then for reimbursement, when we negotiated that consensus document, the terms that we agreed to were things that, again, would specifically help the pharmacists. And we were very clear that we weren't interested in talking about provisions that would increase the cost of healthcare. That said, we said repeatedly to the pharmacists, stakeholders, that if they wanted to pursue separate legislation to deal with reimbursement, they were more than happy to do so, but that was something that we wouldn't that we couldn't agree to in the consensus document. And even beyond that, we did have a commitment at the end of the stakeholder meetings to continue our discussions, because it is very in-depth. It's really hard to understand. We know there's still more work to do, And we made that commitment that we would continue to work even after this legislative session to keep engaging on what problems are you having? Let us go internal to our companies to see what's happening and then come up with some solutions, if we are seeing things that are inappropriate. Two other things. With audits, I know there is already statute for pharmacy audits. We cannot go back 7 years. We are limited to go back 2 years. There's also language in current Wyoming statute that says any money that we recoup because we have done a fraud, waste, and abuse investigation, any money that we recoup is limited to instances where there's actual financial harm to either the payer, the plan, or the patient. So there are already some really nice guardrails in Wyoming statute regarding audits. And the final point is around accreditation. I want to be clear with the senator, with you all, that accreditation is not something that PBMs require of all pharmacies. It's something that we require of pharmacies who have decided to offer specialized services, whether it be mail order, specialty pharmacy, sterile compounding. And the reason for that, accreditation, it's not something that we do. It's actually a national patient safety organizations that accredit. So JCO, URAC, those kinds of, it's not us that does the accreditation. We just require it. But what we're doing that for is, I think Melinda mentioned that a lot of these medicines are, they can be infusions. They manage, they manage difficult disease states, and they require care coordination. So when we require accreditation, we're doing that to make sure that the pharmacies have all the infrastructure and the expertise in place to provide those services safely. So with that, I will, we respectfully oppose this, and I stand for questions.
Just a quick, before we do any comments, any acronyms that you bring up, I know what JACO is.
Oh.
Most people know what those things are, but if you'd spell those out, because
Sure.
everybody listening online and everybody in the room probably doesn't know what those are, so
Yeah.
appreciate you to spell them out.
Yes.
That's fine.
I apologize. So do you want me to do that?
No, I just,
Okay.
hold on to it, it'll come up again. Question, Senator Bouchard.
Thank you, Mr. Chairman. I'm glad that we finally got an answer to who owns the PBM, because when I asked that a year ago, the answer that I got from some of the people that were here were they didn't know what the National Blue Cross did. So they were unaware of who owned the PBM. That was in open committee last year. So I want to get back to what we're talking about here. We have independent pharmacists that are subsidizing some of your low cost. And that's the problem here. We have pharmacists that are not being reimbursed, not because of Medicaid, not because of the government, but because the PBMs are owned by your company. And so that's what we're trying to fix. And this is the second run at it. And you've come to oppose this legislation that is to open transparency. So if you're going to say we're going to work with you, and then we keep hearing no, 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 how are we ever going to get to where we can reimburse these people? Are they supposed to keep working for free?
Chairman Baldwin and Senator Bouchard, thank you for the question. I want to be very clear. The ownership structure of Prime Therapeutics, with our ownership of having 18 Blue Cross, not-for-profit Blue Cross Blue Shield plans, hasn't changed since last year. I've been very clear, I've said that repeatedly, that Prime is owned by 18 Blue Cross Blue Shield not-for-profit plans across the United States. Regarding reimbursement, another statement that was made last year in open committee was a statement from the pharmacists that they were having issues with under reimbursement with 10% of their claims. It's not widespread, as widespread as is being stated.
Okay, Senator Barlow.
Thank you, Mr. Chairman. So I don't know what was said last year, but I want to know what was said in the past 3 months. And so what are the 9 pages out of the current 12 we have that you believe there was agreement on? What in this current bill, is there anything in this current bill that represents the things you believe there was consensus on? Thank you, Mr. Chairman.
Go ahead.
Senator Chairman and Senator Barlow, Yes, there are provisions. What we did was we went through the existing Wyoming statutes for licensure, generic reimbursement, and audits, and added language to each of those provisions. The one provision that I would say that is in this bill that was straight from the consensus document is the ability for pharmacies to appeal generic reimbursements issues in a batch format. So instead of having to do one at a time, it would allow them to send a document or a file that has multiple prescriptions at once that would be processed for an appeal.
Thank you, Mr. Chairman. So that is, I think, page 10, lines 7 through 18. So that's the only thing that made it into this document that was at least there was belief to be consensus on. Thank you.
Chairman Baldwin and
ahead.
Senator Barlow, you are correct.
Further questions, committee? Senator Hutchings.
Back, Lugina. Seems like you like Wyoming. Quick question, comment, then a question. You know, I was in contract with someone to install a wind generator at my house. And I got all the way up to the point where they were marking my property. And I realized, wow, this is being subsidized by the government. I'm getting out of this. And I lost money, but up until that moment, I decided that the consensus I made with that contractor was something I didn't want. So we both know that there are times when you could be in negotiation up until the time you're handing out money and then you change your mind. So I think that's what the pharmacists did. They saw that what was being offered really wasn't to their benefit. Now, quick question. Have you been to any of our local pharmacies and seen the stack that they have? Stacks, not with just one, but just columns after columns of reimbursements that were not adequate. Have you done that?
Go ahead.
Chairman Baldwin and Senator Hutchings. No, I have not been to a pharmacy in the state of Wyoming, but we do have access to all of that information.
Thank you.
Further questions, committee? Seeing none. Thank you very much. Sir. Welcome to Labor and Health.
Good morning.
Great tie, by the way.
Thank you, Mr. Chairman. Good morning. My name is Bruce Spencer. I represent the Mountain Health Co-op. The Mountain Health Co-op is a very small insurance company that writes insurance in Wyoming, Montana, and Idaho. We are looking to get about 18,500 members in Wyoming in 2023, which is a significant improvement over the past couple of years. We've been here for 3 years now. And, you know, the co-op was formed to provide competition to traditional insurers. And that has worked in Wyoming. Upon our entry into the individual market, the rates went down 10%. So competition works. But we are not a big company. We're a small entity. We are not a big, giant conglomerate. But we believe we provide value to particularly rural areas, and we're based in the Mountain West. For example, Mountain Health Co-op has a robust pharmacy benefit. It provides over 250 drugs on a non-cost sharing basis to its members. Some of these drugs are like inhalers that are very expensive, and insulin, which I'm sure you've heard about, and the cost of insulin. No cost share for Mountain Health Co-op members because of this unique pharmacy benefit. But my company cannot offer that benefit without pharmacy benefit managers. They keep the cost of prescription drugs low. And the cost of prescription drugs is the largest share of your healthcare dollar. It's number one. It's ahead of hospitals. It's ahead of doctors. It's prescription drugs. It is extremely important to keep cost in control on prescription drugs for all of the Wyoming members of the co-op. Now, I sent you a letter that addressed specific issues with the bill, and I'm not going to go over that. But I was a part of the interim working group, and I believe we negotiated in good faith. And in the end, we had to agree to disagree on some things. But we did come to agreement, we believe, on several issues. And unfortunately, you don't see those in this bill. I'd like to talk to you for just a moment about the amendment that I have handed out. There are a couple of amendments that we have suggested. There's a group that have suggested these amendments. They're pretty simple. The amendment 1 is delete the entire section 1. The reason why? It was not discussed or agreed at that interim working group. Nothing in there was agreed at that working group. And amendment 1 contains some significant, section 1 contains some significant cost drivers that are certainly important to the Mountain Health Co-op. The number 1 being the prohibition on using mail order for specialty drugs. You'll find this on page 3, line 22, and page 5, line 4 of the bill. I believe that your employee insurance group from the fiscal note also shares this concern. You've heard sort of a definition of specialty drugs. They are incredibly expensive. They are something that you have to keep under control. And PBMs and health plans use mail order pharmacies for specialty drugs because of that cost control. They get a better price. More importantly than the price, however, is the safety aspect. Many specialty drugs do wonderful things. They also have incredibly severe side effects, like can cause suicidal tendencies, and if a patient isn't carefully monitored, you have a death. Or bad side effects that can result in death. The reality of that is that these specialty pharmacies have lots of trained people that connect with those patients on a regular basis while they're taking those specialty drugs and walk them through the process. They're not left alone to just take the drug. That's why these mail order pharmacies are of a great benefit to the health of Mountain Health Co-op members. In addition to price, they have the ability and the personnel to monitor the use of that specialty drug, and that is very important. The second cost driver that is of concern to the Mountain Health Co-op is located on page 2, line 7, and through page 3, line 10 of the bill. And this is the cost shifting of the fees, the costs to run the PBM network. You know, when you go to the pharmacy and you get to the counter, you provide them your prescription, they fill it and you pay it, and they take the insurance copay and they say, all right, you owe $30, right? That just doesn't happen. There's a whole network that has been built by PBMs to create that information quickly. And what the bill does is shift those costs to health plans, because the costs aren't going away. And PBMs are going to say, all right, we can't charge them to pharmacies in Wyoming. We're going to charge them to health plans in Wyoming. So it's a cost shift, and it is a concern, particularly to a small company like the Mountain Health Co-op. So those are the reasons why we request Amendment 1. Amendment 2 is deleting Section 2, except for new subsections K and M. And as was discussed previously, subsection K, which is page 10, lines 7 through 18, is for the most part agreed language that we agreed to in the interim. Subsection M, frankly, is a little controversial amongst the health plans and PBMs. Some didn't want to give that they don't feel it's right that a pharmacy should refuse to fill a script for a customer. But it was felt that because we're asking for so many amendments that, and we offered M in the interim meeting and it was declined, not accepted, but we felt maybe it was appropriate because so many amendments are being suggested that we offer M. The reason for the amendments in Section 2 are that Section 2 is trying to move brand name drugs into the MAC pricing formula. And what MAC pricing is, it's really designed for generic drugs. And this is the way I like to describe it. I'm sure all the people that understand PBMs hate it when I do this, but this is the way I like it. MAC pricing is where a PBM says, here's a list, and for these generic drugs, we're not going to reimburse you above the maximum allowable cost, MAC pricing, MAC, maximum allowable cost. And we get our maximum allowable cost by sort of having a bot go around to all the wholesalers and figure out how much they're charging for that generic drug that week and that time. And then we update our list and we say, all right, I can get it cheapest here. And so that's the most I'm going to pay for it. And the pharmacy says, and this is their complaint, I can't get it at that wholesaler because I have a contract with the Pharmacy Services Administrative Organization and I must buy it through them. Well, the pharmacy is asking the co-op members to pay more for a drug because they made a bad deal with their wholesaler. They're now taking this and they're trying to sort of shoehorn in brand name drugs in section 2 and say, all right, we get to appeal all brand name drug pricing too. Well, PBMs don't have a MAC list for brand name drugs. That's not how they're priced. That's not how the negotiations work with pharmacies. So I'm not exactly sure if this is even workable, but assuming it is, you're now asking Mountain Health Co-op members to subsidize brand name drugs, which could have even a bigger impact because a pharmacist doesn't have a better deal with their PSAO. I think also you should note that there was transparency mentioned in the bill, and I'm not talking about the amendments here, but there was transparency mentioned in the bill, but there's no pharmacy transparency in the bill. Pharmacists get money on the back end that isn't shown in the invoice for lots of things, and they're listed in my letter. Those aren't required to be disclosed in the bill. Those aren't required to be added in and do the math to determine whether we're breaking even or not. You know, you hear horror stories about certain drugs, this particular bill, this particular script, I didn't make money on. But look at the overall picture. Are you making money overall? I believe the answer is yes, and that's fair. Nobody says they shouldn't. Yeah, there are going to be certain drugs that are available for at a wholesaler for a lesser price that my PBM says you should have bought it for that price instead of the deal you got. There are going to be drugs like that. That's how Mountain Health Co-op members save money. That's how that robust pharmacy benefit can exist. So there are absolute benefits to the 18,500 members in Wyoming of asking pharmacies to get the best deal. We don't believe Senate File 151 provides those benefits. We would ask for the amendments. If the amendments aren't granted, then we'd ask you to vote against the bill. Thank you.
Questions, committee? Senator Bouchard.
Thank you, Mr. Chairman. Some of these are the same arguments I heard last year, but we never come back and address how are we going to pay the people that aren't being reimbursed. And so you saying that you're getting a benefit by keeping things the same means that these pharmacists are subsidizing your benefit. And that's what we're trying to get at here. At some point, we're gotta make a change. How is it that Tennessee did a rather extensive change and there hasn't been all these increases and things that we keep hearing that the sky is gonna fall? So, and I think that's because everybody's realizing what's being told here isn't happening. So how is it that Tennessee, the sky didn't fall in Tennessee? If they've made a lot of changes rapidly.
So, Mr. Chairman, Senator, I'm afraid I know nothing about Tennessee. I know about the Mountain Health Co-op and its operations in Wyoming, but I'm afraid I can't answer you about how Tennessee affects things.
Pretty good. Senator Hutchins.
Thank you, Mr. Chair. Didn't really get your name.
My name?
Yes.
Bruce Spencer.
Bruce, thank you. You know, you mentioned on page 3, lines 22, that this bill would eliminate mail order. And it seems to me that it's just giving the patient a choice. Do we want mail order or do I want to go into the pharmacy? Can you explain that to me, sir?
Senator, Mr. Chairman, Senator, yes, it's a very clever way of writing that, but its effect is exactly that, to prevent mail order, to prevent a health insurance company from requiring you to get your specialty drugs through mail order. And that's because if you read the language, a pharmacy benefit manager may not restrict a person's choice of network provider for prescription drugs. Lots of health companies and PBMs say if you have a specialty medication, you're going to need to go to our mail order pharmacy to get it because of the issues I mentioned before. This would say, no, I could go down to the corner drugstore and get it if I want to. We believe that is a cost increase.
Okay,
Thank you, Mr. Chair.
okay. Thank you very much. 4 seats are open. Others in the audience who wish to testify? If the seats don't fill up quicker next time, we'll be calling on the online people quicker, so jump up here. If there's anybody left out there who hasn't testified that wants to, start warming your feet up to come up, please. Go ahead, welcome.
Mr. Chairman, members of the committee, excuse me, Mike Mosier, Cigna. This is going to be a different discussion from the eloquent and knowledgeable ones you've heard before. I'm going to address more policy, being one of the few people that I like institutional knowledge rather than old, but with the institutional knowledge, I remember the last PBM transparency bill we saw, which was 2008. Yes, we've seen them before. We've seen one before. It's just been a while. So I'm going to address policy. I'm no healthcare expert. I'm just a lobbyist. So first of all, I was part of the working group too. I've been part of every PBM working group we've had. I've been part of dozens and dozens of task forces and working groups ranging from workers' comp to juvenile justice to substance abuse and mental health to alcohol to gaming to heaven only knows what. Every one of those groups I've been part of came away with a finished product. Didn't make everybody happy. My idea of compromise is nobody's really tickled about it, but nobody really hates it either. And that's kind of where we were at with this one. With 20 plus hours worth of meetings, similar to 2015. Some of you remember the substantial PBM legislation we did, which was arduous but successful. We reached a good conclusion. We thought we'd had that. As was mentioned before, the draft bill was agreed to, submitted to LSO by the House Corporations Chairman, and then about a week later, somebody changed their mind. And that's why we're here. The one thing I want to, and I apologize, Mr. Chairman, for being a little more simplistic, but I have nicknames for bills. We have zombie bills, Lazarus bills, both resurrection, depending on whether you're rooting for it or not. You have unicorn bills. And this type of bill and its brethren, because as you probably know, there's House Bill 191 on the other side that's dealing with the same issue, except in a more expansive way. I name after a movie about a guy who had a problem with a little gopher. And instead of getting out to 22, he blew up the entire golf course. I call this a Caddyshack bill. Instead of addressing specifically the issues at stake, rural and independent pharmacies, we're blowing apart the entire system, and in the process may not actually get the solution we seek. Let me elaborate a little bit on that collateral damage. You heard in testimony that 70% of prescriptions filled by Blue Cross Blue Shield are to chains. You heard that almost 90% out of the EGI are to chains. Instead of specifically addressing rural and independent pharmacies, I've talked a lot of you about these issues, and I have yet to hear a senator or representative say, you know, Mosier, those rural and independent things are really good, but I'm really concerned about the big chains that are buying up the other chains. We need to make sure they make more money. Our concern is rural and independent pharmacies. What we need to do is put our crosshairs on that. Now, it was raised during the working group a number of times, but it was shot down immediately because ways to address, and there are ways to address rural and independent pharmacies are not supported by the chains. I'm not knocking chains, but they're not charities and they're not going to support something that doesn't help them. And so if we focus on rural and independent pharmacies and how to assist them, and like I said, there are different ways to do it that other rural states have done, that would be more addressing the problem and you wouldn't have the collateral damage. Tying into that, if you increase the profitability of pharmacies, you're going to have more pharmacies open, but they probably won't be independents. Because a lot of chains can add a lot of pharmacies with little build on. And so my concern is that actually, I kind of feel like a parent that's talking to one of my kids and saying, you know, those people that say you're your friends really aren't your friends. Our concern, and we need to focus on our concern, is rural and independent pharmacies. So lastly, and I'll wind up here, it was Senate File 78 in 2008, PBM transparency. And it obviously Senate file cleared the Senate committee 3-2. But about that time, employers started realizing what it would do to their healthcare costs. Individuals like me that pay my own health insurance realized what it would do to their healthcare costs. We didn't do much lobbying on Senate File 78 because it never came up on committee of the whole, because people realized that it was a mandate on health insurance, on the health insurance system, that was going to cost everybody more money. That's the collateral damage. Whether it's now, I hear testimony that says, well, it really won't cost you more. Well, every accountant and every group and every employer I've talked to who's looked at it says it'll cost them more. I would rather focus on that individual concern you have, rural and independent pharmacies, and their feasibility. Now, bear in mind, they're not going out of business. The numbers remain pretty stable, but I realize there's a lot of struggles with them, and we want to keep them. We want to have those independent pharmacies, especially in rural communities. But let's narrow down and focus on addressing that issue rather than running a Caddyshack bill and just seeing what happens. With that, and with the amendment, by the way, Mr. Chairman, we would support it. I think it takes it closer back to what the agreed to language was. I still think there's negotiations possible. I'm just really disappointed that I thought a pretty good draft bill that was about the same size as House Bill 35 that we did in 15 just died after 20 plus hours of work, although it seemed like 200 hours, but that was just me. So with that, committee, I will take any questions. Thank you.
Questions for Mr. Moser? Senator Bouchard.
Mr. Chairman, thank you. You know, we're here today because the bill that we wanted was one that said you have to reimburse at least the cost of the drugs. And so, and I say you, I'm talking about the PBMs. So when we have someone in business that buys a product, then they find out after they put it over the counter that they're not even going to get reimbursed their cost. That's the problem here. That's what we keep coming back to. And when we put that out on a bill, nobody wants it. There was lots of testimony saying that's going to raise costs. Maybe it would raise costs, but it would give people their fair share. But what we see in other states like Tennessee, it hasn't raised it. So something's up here. We keep coming back to the table saying no, no, no. I want to come back to how are we going to reimburse a cost of a product that's been put over the counter and the independent pharmacists are subsidizing it. That's what we're trying to do here. So, and I keep hearing no. How do we get there?
Mr. Moser.
Mr. Chairman, Senator Bouchard, as I mentioned before, that I'm not a healthcare expert. I'm not getting into the weeds on that. However, I do know states, and I think there are others in the room that would know, that classify rural pharmacies as in a different category. There's a lot of health plans that have different dispensing fees for independents versus chains. Like I said, chains aren't going to support that. And we don't have a position on any of those. But on the other hand, once again, you can address the issue without going Caddyshack on it and blowing the system apart and costing everybody more money. I would like to fix the problem without costing everybody more money. That would be my concern, and that's really where your opposition was. Senate File 36, if you saw the list of opposition, it was a lot of major trade associations, municipalities, because their accountants came to them and said, this will cost us a lot of money. And so we want to avoid that if possible. Mandates tend to do that, but if we can address rural and independent pharmacies separately, you're talking about a lot lower fiscal impact because Like I said, only a little bit over 10% of the EGI, the state health care plan, is even independent pharmacies anyway. Everybody wants to help these guys. They're important to communities. But on the other hand, is this the direct approach to do it? I do not believe it is.
Thank you. Further questions, committee? Senator Hutchins.
Thank you, Mr. Chair. Mr. Mosier, I kind of didn't like your Caddyshack analogy. It was a little disrespectful when we're talking about people's livelihoods. You have the big change, you have the big dollars going to the PBMs, money disappearing where no one knows where it's going. You said you've been working with this since 2008. That's a long time to make these people wait and suffer and try to decide should they stay in business without offering them any kind of solution. Should we just continue to do nothing or try, like other states have tried, to rectify this situation? This is a national situation. It's not just local or rural. So tell me, what should we do?
Mr. Chairman, Senator Hutchings, we have been doing a lot. 2015, well, currently there are still states that don't go nearly as far in licensure and regulation of PBMs. Is this an ongoing process? Yes, that was one of the things in the working group that was mentioned before, is this is an ongoing process. It needs to be revisited constantly. Also, the federal government is doing stuff on this level that is way beyond our purview. And so, Senator Hutchings, the problem is, and I'll admit we make a lot of fixes like we did in 15. We did some fixes in 2019. We just need to continually revisit these issues because the landscape is changing. But part of the reason it's changing is because the big guys are eating up the little guys. And if we want to protect our little guys, we want to be able to do it separately.
Okay, I would remind the committee that we've now taken an hour on this, so we need to keep moving if we want to get through it. Otherwise, this will be extended and go on to another meeting. But go ahead. Senator Bouchard.
Thank you, Mr. Chairman. I mean, I think we need to revisit the 70s because the PBMs used to be independent and now they're all owned by either insurance companies, by big box stores that all have a central interest in mind. And that interest is not reimbursing on some of these drugs. So again, that's a lot of words that you said, but we're not talking about how we're going to fix reimbursing those for those drugs. That basically we're just saying you eat it, and they can't continue to eat that cost.
Response, Mr. Moser?
Mr. Chairman, I didn't see a question.
Okay,
but thank you.
that's good. Okay, let's move on to the next session.
Sir, I did
Go
have a
ahead,
question.
Senator Hutchins, quickly, please.
Quickly, Mr. Mosier, have you gone to a pharmacy, even your local one, that's pretty much right down the street from your house, Mr. Schmidt's pharmacy, and asked him to show you what he's going through in his pharmacy? Thank you.
Mr. Moser.
Mr. Chairman, Senator Hutchings, I don't think I'd want to try that. Just go in and see somebody's books. That's not something a layperson would do. So if Mr. Schmidt would be glad to host me, I'd be glad to visit his pharmacy. He runs a fine business. And like I said, we want to make sure these guys stay in business. So we need to do what we can. Thank you.
Thank you. Go ahead, ma'am.
Hi, my name is Diana Mavig, and I'm a consultant with Agile Benefits and Novo Benefits. You know, I battled a lot last year on SF 36 because there were components. Yes, there were components that I didn't think were helpful in anything, and the impact of it financially to employer plans was going to be staggering. But if I look at it in an open mind, because I also sat on our committee with 20 hours inside of a room, reminding myself why I would never want to do this for a living. And through the course of it, how do we go into a capitalistic free enterprise system and say, we're going to regulate contracts. We're going to regulate your hidden contracts that we don't even know what the reimbursements are. And it's something that I myself have battled for many years with my clients and inside of groups, because the PBM is one of the hardest components of a healthcare plan to control. And it's the reason that you see TPAs managing with certain contracts, but the majority of my groups are self-funded accounts. And when they are, we get to see a little bit more data, but we still don't get to see the hidden contracts. But I can tell you, I have a 2-page document that we wrote many years ago on PBMs to just say, if you want to play, you have to abide by the rules. A lot of those rules are in SF 151. And since I'm kind of novice at coming to the legislature, I didn't go in and break mine out and say, okay, line such and such says this. I did it in my little cliff notes inside of my own document. And if you guys ever want to see it, I'm happy to email it to you. But through the course of it, here are the big points. Already, we don't like spread pricing. We're with the state on it. I don't think it helps. Any revenue that a PBM makes should be generated off of one thing, and that's an admin fee. They shouldn't make any revenue off of a cost containment tool that they're plugging in that would create a disparage when it gets paid down at the pharmacy level, because we're going to wipe out retail pharmacies, which has been a catastrophic event that really started with Medicare Part D. And when the Affordable Care Act overlaid over the top, it wiped them out. And Wyoming was a prime example of how we have struggled with that. I have spent time with the independent pharmacists trying to see their side and what they've been up against. And when I would go back and compare it to our little "you can't do this" list, it was pretty comparable, you guys, to the same thing of you can't do that because it's not really fair. I don't know how we go in and legislate a completely transparent contract between one corporation and another corporation, where everybody sees the components, because on the backside of it, we have too many of them that have non-disclosure agreements with pharma, big pharma, and we can't see what that means and the impact of it. But when we build a formulary, the formulary has to be, one, effective to the member that's using it, and two, effective and cost-effective for the employer that's writing the check for the claim. So as I go through this and I look at it, big items for me. We need to have no PBM that could retain even 1% of a rebate. It needs to get passed back to a fully insured insurance company or to an employer-sponsored healthcare plan. We need access to utilize coupons when they're available and alternative funding when it's available, because it helps buy down this massive bubble of cost that's been hanging over our head. Do I look at it and think, if Blue Cross says SF 151 is going to cost $7 million to the state, and we can carve out and allow employers and insurance companies to still use coupon programs that Big Pharma has set up, and any other money that we can find to help buy down those large specialty medications that sometimes can be $600,000 in a year for an employer. Those are the things that we have to target. That if there's money available, let us target it. If there's money not available, then if there's a better pharmaceutical option for that employee, or at least an equivalent one, please let us steer to that. Thank you.
Questions, committee? Senator Barlow.
Thank you, Mr. Madvig. So I do want the amendment. I do want to know what 6 things or 5 things or 8 things in this bill, because right now there's just too much noise in this bill for me. I'm just being candid, everybody. So if there are things that do need to move forward or will make a difference, I think at least, anyway, I would appreciate knowing what those are. And if you want to provide them separately, if this bill makes it out of this committee and it goes to the floor, then I'll be looking for that guidance. Thank you.
Senator Rockstetter.
Mr. Chairman, to avoid the confusion, can you combine them all?
Pardon?
The amendments?
All of the amendments.
Yeah, how many?
So I haven't gone through, that's why I apologize. I haven't gone through, but I'm happy to email it to you guys. You'll see my cliff notes. You'll know why Mrs. Higginbotham gave me a small C for penmanship, but I'm still happy to give it to you and let you look at it. There's a couple things I have for sticky notes that I'll just transfer on there. And you'll see, because the steerage component on where we're purchasing specialty is a critical aspect for healthcare plans to have control of that and insurance companies. And the majority of specialty meds, they don't run through our independent pharmacies or our big chain pharmacies. It just doesn't happen. If we get something, it's one fill and then we capture it and try and move it out to contain costs. But I'll go through, clean that up a little bit and email it to all of you.
Thank you. I believe we could
There
work
won't be
with
any
you.
grades against your
Yeah, I
penmanship,
was
by the
gonna
way,
believe we can work.
because you
with
haven't seen my
penmanship.
penmanship yet.
We're good with it. Send it.
Senator Barlow.
Thank you, Mr. Chairman. So based on your participation in the group that worked up until some point in November, what portion of it is reflected in this bill, or what portion would your amendments or your suggestions bring into the bill? Because I think we've heard there's one in this current bill. What would you say comes into the bill? Thank you.
Go ahead, Ann.
So I think the biggest thing that we see, I don't like the way PBMs can go back in and do an audit on an independent pharmacy. I know if they have a PSA, PSAO is gonna do some of the audit management, but some of it doesn't. I can tell you as a small business owner, what a nightmare would be to go through it. But as I went through the bill, some of the language is ambiguous, which made us all sit here and think about it and go, all right, I think it means this, but I'm not 100% positive. You'll see my question mark on there, followed by a couple little acronyms that are like, what the heck does that mean? But as we go through, I think us on that committee, we're trying to get to a certain place. It was a frustrating scenario to sit in the middle of because PBM didn't want to concede on certain points, and they're not conceding on it for a single reason. We have to have a robust PBM that can manage the prescription from the time it hits and goes down through the pharmaceutical chain to be handed out to the employee. We have to have a good PBM program, but we don't need to have all of the cost containment that tightens back and allows clawback to go back in. I met with one pharmacist and he said in a single month, he got a clawback for $75,000. It's a lot of money and a clawback on an independent pharmacy. And when I said, how did you go through your information and how did you ascertain whether or not the clawback was an accurate number? And the question was, I can't even tell why the clawback occurred. And when I went into my contract, I couldn't find in the contract anything that would have triggered it. And when I email in to inquire about it, I'm not given a response that allows me to still get to the bottom of it to say, Senator Hutchins purchased a prescription and it was a high blood pressure medication. That high blood pressure medication was changed 30 days later because it didn't work for Senator Hutchins. So Senator Hutchins went through 2 changes or 3 changes in a single year, which changes some of the outcome basis and measurement tools. And I can tell you in our own software programs, when we dive into pharma, we struggle with our own software systems to be able to go in and ascertain whether or not Senator Hutchins is actually compliant with her high blood pressure medication because the algorithm doesn't let us separate it out. Even though she's compliant and it took 2 or 3 scripts to get there, it's still screwed up. So if we're paying and clawing back on something like that for an outcome basis, that is part of the problem because we can't vet it out.
You're delving into my world now.
Yeah.
Senator Barlow, go ahead.
Thank you, Mr. Chairman. So last class, how many lives do you represent or do you consult on in Wyoming? Thank you.
I should know this number off the top of my head and I don't. I'm going to say maybe 9,000-10,000. And that'd just be employee lives. It'd be like 2.4, 2.5 if I looked at belly buttons.
Okay.
Thank you for not looking at the belly buttons.
As long as she looks and we don't have to look, that's okay.
Oh, they're cute, some of them.
Okay, let's move on to some other testimony in the room.
Sir, I had a
Go
couple
ahead.
questions for Diane, if you don't mind.
I don't, it's your time. You go
Yeah,
ahead.
thank you. You mentioned outcomes, and I know sitting with some of the pharmacists, it seems like they're being dictated by the PBMs or some higher source power on outcomes. You're saying that you guys care about the outcomes of the medicines that I'm taking. Can you help explain to the panel what these outcomes mean and what they mean to the pharmacists? if I'm not taking my drugs the way I'm being told to take them, the pharmacist is kind of dinged on it. And then I want to also mention, you said the PBM portion is the hardest to control, and that's what we're trying to do with these bills, is to control them. And then when the PBM is constantly changing the parts of a contract, how is anybody supposed to operate like that? 3 questions if you can.
Go ahead, Diane.
So let me start with the first one. So on outcomes off of it in a healthcare plan, especially an employer-funded plan, it's critical. We want to keep the employees as healthy as possible. If we could prevent Senator Hutchins from having a stroke or a heart attack because she is non-compliant with her high blood pressure medication, it's a win-win. The employee has a healthier the employer has a healthier employee, and the plan stays healthy, and we don't end up with large claims. So it's something that's very important inside of it. What was your second one, Senator Hutchins?
Again, the pharmacist is now in control of the patient's outcome. That was the first one, and you just kind of said, yeah, we want the patient to be healthy, but why should the pharmacist have to bear that burden? Then number 2 was, you said that was a comment, the pharmacist is the hardest to control. And the question, the last one was, if the contract is constantly being changed, I'm believing on the PBM's part, what's a pharmacist supposed to do with that constant change?
So I think on the PBM side is really what I said, the PBM component is the hardest to control, right? Because of it, we don't get to see a lot of the backside, right? It's like the Wizard of Oz. If you ever get to the back of the screen, you're like, oh, that was not what I expected. But it's also, it's not so much that the pharmacist is compliant with it, because it's everybody in particular. A pharmacist isn't going to go in and change a prescription without reaching out to the doctor. If a patient came in and said, hey, I'm coughing with my high blood pressure medication, then that's a potential reaction to some of them, right? So then they're going to reach out to the doctor to get a change on the script as much as anything else. And then on the PBM side of it, I think the PBM, it's their job to make sure that we're trying to stay as compliant as possible. And I'm going to use an example. If we had someone that was non-compliant with their diabetic testing, is that an indication that potentially they just are not managing as effectively as they possibly could? And to me, the answer is yes. If they're testing, once a day instead of 2 to 3 times a day, or with some people I even know that test 4 to 5 times a day, then we need to be able to understand what's triggering that and hope that we can do it. We could actually go in on my side and overlay a different vendor that would allow us to reach out specifically and target a diabetic to help encourage them to do it. We can also go in and create free test strips and free medication that will make it easier for a member or an employee to be able to go in and keep and manage a disease that can have a catastrophic financial effect on a healthcare plan if they end up on dialysis or have complications from it.
Okay. Thank you very much. Further testimony from the room. Anyone else in the room? Last call for the room, then we're going to move online. Okay, let's move online. I know we got several folks waiting.
Yeah, Mr. Chairman, we have several people online. If they would all raise their hand, anyone that would like to testify.
Okay. Raise your hand quickly and we'll get you in.
Mr. Chairman, I've admitted Lucas Cootie and Michelle Mack.
Okay.
I'm sorry, I was in the middle of, did you, there was a little bit of a lag.
Okay, and you are, Michelle, that's Michelle, is that correct?
Yes,
Yes, go ahead, Michelle, introduce yourself and go ahead and address the committee.
perfect. Good morning, Chairman Baldwin and members of the committee. My name is Michelle Mack, and I'm a Senior Director of State Affairs and represent the Pharmaceutical Care Management Association, commonly referred to as PCMA. And I appreciate you allowing me to testify virtually. I apologize I wasn't able to make it today. I am in Minnesota, so I'm enjoying the cold weather just like you are. So I'm feeling your pain. PCMA is the National Trade Association for Pharmacy Benefit Managers, or PBMs, which administer prescription drug plans for more than 275 million Americans with health coverage provided by large and small employers, health insurers, and labor unions, and federal and state sponsored programs. We appreciate the opportunity to testify, and PCMA respectfully opposes Senate File 151. I don't want to duplicate any of the testimony that's previously been said relative to the opposition. But just wanted to point one thing out. There has been some talk about the spread pricing, and I know a lot of the companies do not use it in the state. But you know, the reason why it is offered is because our clients want a variety of contractual options to pay for PBM services, and they choose the one that's best for them based on the services that they need in their plan membership. Each employer and plan sponsor evaluates and determines the financial arrangement that meets their specific needs for PBM services, and this takes that away from them. You know, there have been some negative comments about PBMs, but what you didn't hear about PBMs was that we save payers and patients 40 to 50% on their annual drug and related medical costs compared to what they would have spent without the PBMs. In fact, we save payers and patients an average of $1,000 per person per year. And we also improve drug therapy and patient adherence in diabetes, and we help reduce emergency department visits, heart attacks, strokes, amputations, and incidents of end-stage kidney disease. At the end of the day, no one's required to use a PBM. This bill amounts to government interference in the private market, and in the end will only drive up costs for healthcare, as it will seriously undermine the ability of PBMs to help with the control of drug costs. This amounts to an unfunded tax on businesses and is choosing winners and losers in the marketplace. I do note there was some questions about the Tennessee law that has been in place, and there was some note that there was a study that had said that it did not increase costs. I just want to note that that study looked at premiums. The prescription drug costs are only 20% of what goes into that premium. So in addition, the Tennessee bill was passed in 2019, and it was effective July 1st of 2019. So those premiums pretty much were almost set at that time for the next year, for 2020. And looking at 2020 and 2021 was just an abnormal. I mean, those just weren't your typical years. So comparing that data and saying that it had no effect, I would say it's just too premature. I will also add that there are still regulatory hearings, and actually there is one going on this week relative to that statute, so it is still in flux. I thank you for your time and consideration, and I'd be happy to answer any questions.
Questions for Ms. Mack? Senator Hutchins? No. Oh, you had your finger on the button. Any other questions? Thank you very much. No questions at this time, Ms. Mack. Appreciate you coming. How cold is it there, Ms. Mack? Oh, she's gone.
Oh, actually, it's -5 with a 20 below wind chill.
Okay.
Same as you.
You're very similar. I will tell you, it's 71 degrees here in the room. Thank you very much for appearing. And the gentleman up in the corner, I believe that might be Mr. Cootie. Is that correct?
Yes, sir, Chairman. Yes, sir, Chairman. Thank you. My name is Lucas Cootie. First, I want to let you all know that even in Southwest Oklahoma, it is 19 degrees, it is sleeting, and it feels like 5 degrees. So nobody is safe right now. I just want everybody to know that. So again, my name is Lucas Cootie. I'm a pharmacist and the Director of Government Affairs for AlignRx. AlignRx is a pharmacy services administrative organization, or PSAO, that assists community pharmacies with contracting, payment reconciliation, and reimbursement appeals. This testimony will help you dispel any misinformation that you may have heard by sharing how sections of this language have already been tested in courts and has been ruled to be constitutional, enforceable, and not preempted by federal ERISA laws. Lastly, I will leave you with one very simple question. Much of Senate File 151 deals with transparency. We've heard that. Let's discuss a few common business practices that are not transparent. Senator Hutchings spoke on several business practices, such as the unnecessary fees and clawbacks from pharmacies. Those are certainly not transparent. I won't spend too much time there. A PBM stating that a pharmacy must appeal any reimbursements through their PSAO, but then refusing to accept reimbursement appeals from a PSAO is not transparent. A PBM charging an employer or a health plan $100 for a prescription claim, but then only paying the pharmacy $15 for that claim is not transparent. Senate File 151 protects patients, pharmacies, and plan sponsors by prohibiting some of these unacceptable business practices. States such as Arkansas, Montana, North Dakota, Oklahoma, Oregon, and Tennessee have already enacted similar legislation. Rutledge v. PCMA of Arkansas, PCMA v. Wiebe of North Dakota, and PCMA v. Mulready of Oklahoma have already ruled that ERISA plans do not preempt states from regulating PBMs, and have all suggested that states should do so. Another important piece of Senate File 151 involves fair reimbursement. Expensive medications account for most of the drug spend in a community pharmacy, but in Wyoming, there is currently no protections in place that ensure a pharmacy is being paid even their cost to acquire the medication, let alone the cost to cover the staffing or necessary equipment needed. Senate File 151 includes provisions that will allow pharmacies to submit an appeal to the PBM when they are not able to purchase a brand name medication at the rate the PBM is reimbursing. PBM contracts often require, they do require pharmacies to fill every prescription, even if the pharmacy is losing thousands of dollars on the claim. Community pharmacies cannot continue to take these substantial losses and keep their doors open for their community. Denying a prescription fill is something that no pharmacy wants to do, but in order to protect the community and protect the viability of the business, it's a safety measure that we have to put in place. And similar language has been put in place in states such as Arkansas, Delaware, Louisiana, Mississippi, Montana, New Jersey, Oklahoma, and Oregon. Again, these cases have been heard and ruled in favor of the pharmacies in the state. The last topic I want to address is competition, or the lack thereof, that we commonly refer to as patient steering. In most cases, the PBM is steering the patient to a pharmacy or a mail order service that the PBM owns itself. In a frontier state such as Wyoming, where resources such as healthcare are often limited, why is it acceptable to steer patients to a pharmacy miles away when a trusted local pharmacy is available? States such as Alabama, Arkansas, Georgia, Indiana, Kansas, Kentucky, Louisiana, Maine, Maryland, Michigan, Mississippi, Minnesota, Montana, New Jersey, North Carolina, Oklahoma, Oregon, Pennsylvania, South Carolina, South Dakota, Tennessee, Texas, Virginia, West Virginia, and Wisconsin have all put measures in place to prohibit either mandatory mail order and or patient steering. The last question that I wanted to leave you with, and I do have plenty of answers, as I am a practicing pharmacist and have been in the profession for 11 years, I do have quite a few responses to some of the questions that were previously asked. But the last question I want to ask you is, when has introducing transparency and competition into the marketplace ever increased price? I want to thank you very much for allowing me to share my support of Senate File 151. And I ask that if you want to make a positive difference in the lives of Wyoming citizens, I ask that you respectfully support Senate File 151 as well. Thank you for your time.
Question for Mr. Coody. I think he should pursue a career in auctioneering as well as he did those lists. Any questions for Mr. Coody? Senator Hutchings.
Just quickly want to thank you, Mr. Coody. You spoke so fast, I'm going to have to listen to this information again. But we really appreciate your coming in, and you actually did answer a lot of the questions I did have. So thank you.
Okay.
Quick comment.
See no further questions. Thank you very much, Mr. Coody.
Thank you.
Stay warm. Okay, we have another gentleman on there, and I can't see who it is.
Mr. Chairman, I admitted Matthew Meyer.
Matthew.
Good morning, Mr. Chairman, members of the Senate Labor Committee. How are we doing this morning?
Really good. Again, I compliment you on the pictures behind your head there.
Yep, my 7-year-old is definitely the artist in the house. But I'm not gonna spend a lot of time going back over what we had prepared here, because most of this has already been addressed. And rather just kind of try to focus on some of the points here that were presented during testimony. To start off with the rates at independent pharmacies being filled for the state EGI plan at 10.8% independents, and then the rest coming through with either mail order or big box corporations. A lot of that has to do with benefit design, and when the PBMs put in these contracts, again, they have the right, as dictated in contract, to determine which pharmacies are going to participate in which networks, and also at what price points patients are going to be paying at the pharmacy counter. And a lot of that can influence where you are going to go and have those medications filled at, being dictated by a company, by the PBMs, basically. Commenting that the rebate programs would disappear if EGI moved away from the current PBM contract that they have in place right now is not true. Independent pharmacies process those exact same savings cards, coupon cards that mail order does, as well as box stores do. The other problem with the definition of specialty meds, what is a specialty medication? There is no definition of a specialty medication. So really, I mean, it just allows PBMs to throw whatever medications they want on there. One of, again, the common examples that we constantly use is enoxaparin or Lovenox. It's a very inexpensive anti-blood clotting agent used a lot of times after surgery. We actually have PBMs throwing that on their specialty list. So we get patients on Fridays that just got out of surgery going into the weekend. Prior authorization required, can't dispense it, specialty pharmacy only. Patient has to pay for it, or we have to eat it and wait until Monday till somebody in the PBM's office is available for phone call to get an emergency one-time fill. Nobody compensates us for that, all the extra time to make that phone call in to get that medication approved on the patient's insurance. As the same with when patients come in for consultations on their specialty mail order meds, we are constantly discussing medications that patients receive for mail order in our pharmacy, because they can't get a hold of whoever shipped or filled those medications, or have questions that weren't appropriately answered. Touching on the working group again, that's been a little bit of a heated contention, I guess. But saying that there was consensus on the bill when you fail to address 2 out of the 3 issues that you originally agreed to discuss, and then refusing to discuss them, I would disagree that we had a consensus on that. And again, I missed the last meetings due to some family health issues, so I apologize for that. In terms of accreditation, PBMs requiring accreditation into the pharmacies, that's really beginning to take a step over into the regulatory industry of the state board and patient safety. When did the PBMs become the authorities to regulate the government in terms of the citizens of Wyoming's, when they have foundations in place and they have a whole board that's devoted to patient safety? We're just all of a sudden handing that authority over to PBMs, whose sole purpose is to focus on the profits of their shareholders. As the FTC said, that they have no fiduciary responsibility, even though that they claim to reduce costs for these health plans. I would like to comment on Mr. Cootie's comments regarding, when did transparency ever increase costs? In fact, generally transparency reduces those costs. The PBMs do have complete access to our books, and in terms of the rebates that we supposedly receive from the manufacturers, most of any of our cost savings that we see in the generic market are applied towards the brand name to reduce our costs on our brand name items, so that they can meet contract, or so that we can try to minimize loss damage from dispensing those medications. The other comment that pharmacies only lose on 10% of their claims. That may be a fairly accurate statement that we are seeing 10%. We are seeing underpayment on approximately 10% of our medications. The difference is the severity of under reimbursement on those high dollar brand name items versus what we are receiving for reimbursement on those other 90%. It takes a lot of $2 to $3 fills to cover, a $200, $300, $400 loss on any one of those high dollar items. Most of what the PBM practices in terms of clawbacks are even kept within the PBM themselves, not even passed back on to the plan sponsors. One of the things that has been introduced into recent years is effective rate pricing, and outlined in your PBM contract, it will state that the PBM has the right and the is applicable to the section obligation to manage the overall annual effective rate guarantees as referenced on an aggregate basis for its entire book of business. So within the PBM contracts, they are not even taking a look at the sponsor level on a lot of these clawbacks. If they're not taking a look at the sponsor level, but the aggregate level, that those dollars are not being returned to the plan sponsors because they're not being calculated by the sponsors. So again, they're just ways for the PBMs to increase their profitability. They're not going into to help eliminate or reduce costs for the insurers, for the payers.
Matthew, can I get
yes,
you?
sir.
Can I get you to wrap up here fairly quickly?
Absolutely. Last thing we'll just comment on is spread pricing. Spread pricing in and of itself is a conflict of interest. Here in Wyoming, we have laws on the books that in healthcare, physicians cannot even own pharmacies because of a conflict of interest. And in today's current market with the PBMs, there is absolutely no regulatory oversight against their own conflicts of interest. So at that point, I'll stand for questions.
Thank you very much, Matthew. Questions, committee? Seeing none. Thank you very much. I see another gentleman in the middle there with a great haircut. Go ahead and admit him.
I admitted Joel Kurzman.
Go ahead, sir.
Thank you very much, Mr. Chairman and members of the committee. It's a pleasure to be with you this morning. I appreciate the opportunity to speak with you. My name is Joel Kurzman, and I serve as Director of State Government Affairs for NCPA, the National Community Pharmacists Association. I'm very pleased to speak with you today in support of Senate File 151, which would help control drug costs in Wyoming. It would provide greater protections for patients regarding their prescription drug benefits programs and establish greater PBM oversight. NCPA, by way of introduction, represents the interests of America's community pharmacists, including the owners of more than 19,400 independent community pharmacies across the U.S. and 46 independent community pharmacies in the state of Wyoming. These 46 locations employ more than 560 Wyoming residents, and they filled nearly 3 million prescriptions in the year 2021. Community pharmacists have long known that opaque PBM practices not only hamper patients' ability to obtain pharmacy services from their trusted community pharmacists, but those practices can also lead to higher drug costs for both patients and plan sponsors. Due to massive consolidation and vertical integration in the health insurance market, the three largest PBMs control 80% of the prescription drug market, giving them the power to engage in abusive practices which limit patient access, increase drug costs, and threaten the viability of small business pharmacies. Senate File 151 would address some of those practices that are threatening patient access to community pharmacy services and raising costs for both patients and plan sponsors. In light of some of these concerns, I'd like to just share the provisions that we strongly support in the bill. We strongly support the bill's transparency and oversight provisions under the authority of the insurance commissioner. In particular, we support the provisions enabling the insurance commissioner to investigate PBMs and to promulgate rules for implementing the law. To these ends, we strongly support the appropriations provisions for the Department of Insurance so that they can develop the PBM-specific expertise needed to make possible the enforcement of the law. Senate File 151 would limit PBM conflicts of interest that limit patient choice and raise out-of-pocket costs. It's not uncommon for the PBM to usurp a patient's authority to make their own healthcare decisions by steering the patient to a PBM-affiliated pharmacy, often a mail-order pharmacy. The PBM is then free to reimburse the pharmacy at higher rates than other pharmacies, thereby forcing patients and plan sponsors to pay higher costs to the PBM. Senate File 151 would control this conflict of interest by prohibiting a PBM from reimbursing non-affiliated pharmacies at lower rates than the PBM's affiliated pharmacies and steering patients with various incentives. The bill would also prohibit retroactive clawbacks that end up increasing out-of-patient costs for patients. Others have spoken to this a bit already. When a PBM has reimbursed a pharmacy for filling a prescription, it's not uncommon for the PBM to claw back a portion days, weeks, or even months later under the guise of effective rate conciliations or transaction fees. However, a patient's cost is not similarly adjusted. That means that when a patient's cost share is based on an inflated figure, they're paying more than they would need to. Senate File 151 will ensure patients' cost shares more accurately reflect the true cost of their healthcare services. NCPA also supports the bill's reimbursement provisions that clear guidelines for maximum allowable cost reimbursement schemes and facilitates the process by which a pharmacy can submit appeals. In cases where the reimbursement is below cost, we support the pharmacy being able to choose whether or not to fill the claim at a loss. So in conclusion, we feel Senate File 151 would protect patients and pharmacies by putting an end to costly and opaque PBM practices. To protect patient access to vital pharmacy services, I respectfully ask for your support of the bill. I'd be happy to try to answer any questions you may have. And thank you again for the opportunity to speak with you today.
Thank you very much, Mr. Kurzman. Any questions, committee? Okay, my intention is to take one further online testimony. Let's go ahead and admit that gentleman there.
I've admitted Mr. Gagliardi.
Okay.
Thank you, Mr. Chairman. My name is Tony Gagliardi. I'm the Wyoming State Director for the National Federation of Independent Business. It comes as no surprise to many of you that NFIB is supportive of Senate File 151. The original idea behind PBMs made some sense. Their goal was to help employers and insurance companies manage drug spending. Eventually, bigger companies bought smaller companies, others were purchased by insurers themselves, and others by huge drugstore chains. As you just heard, 3 PBMs control over 77% of the market. The practice of rebates and spread pricing have increased the price of prescription drugs to the health plans more than any other factor because of inflation of the manufacturer's price. That is why PBMs and certain health plans are opposed to a prohibition on rebates and spread pricing. The methods of operation used by PBMs are particularly punishing in heavily rural states like Wyoming, making it difficult to get affordable medicines. Wyoming citizens need at places convenient for them to pick up. Independent pharmacies are not asking for special treatment. They are asking for a level playing field. In August of 2022, NFIB polled its Wyoming members, asking them if the state should require PBMs to fully disclose their pricing methods to pharmacies and consumers and to allow for pharmacy of choice. Over 70% of our members favored that idea. Bear in mind, no one is asking PBMs to go out of business. We just want their methods to step out from behind the curtain and into the sunlight of scrutiny. PBMs are under such scrutiny as to cause U.S. Senator Maria Cantwell of Washington State and Republican U.S. Senator Charles Grassley of Iowa, a bipartisan group in Congress, has introduced in 2022, introduced Senate File 4293, the Pharmacy Benefit Manager Transparency Act. The cost of healthcare has been small businesses' top problem for more than 30 consecutive years, according to NFIB's Quadrennial Small Business Problems and Priorities Report. No other issue of the other 74 the report measures has ever knocked health insurance off its perch. Quite simply, the reason is cost. Only 31% of small businesses with less than 50 employees can afford to offer health care to their employees. In local communities and rural areas, the pharmacist is at times the only link between the customer and medical attention. Should a local pharmacy be forced to close, that link goes away. I am here today requesting that this committee continue the efforts of PBM transparency and restore a level playing field with the independent pharmacies. Please pass Senate File 151. Thank you.
Thank you very much, Mr. Gagliardi. With no questions, let me be transparent. That's the word of the day. What we're going to do, committee, is we're going to close public testimony today. We're going to come back Wednesday morning. We're going to place this bill at the top of our agenda. No further testimony will be taking. We will go ahead and work the bill first thing when we come in Wednesday morning, work this bill before we move on to our other two bills, if that's agreeable with the committee. Okay. With that, we'll close today's meeting and we'll be back Wednesday morning to work this bill. Thank you, folks, for coming. Even those of you that didn't get up and testify, thank you for coming in.